Welcome to the Doctors Hospital Distinguished Lecture Series. Every month we invite members of our medical community to speak on topics that matter to you, the Bahamian public. We trust that you will find this information useful. Now sit back, listen, and learn. Isn't your health worth it?
And welcome again. So the intent of tonight's presentation is to get you to view obesity differently. And there's a classical view of obesity. And that view is that somebody has lost their discipline or lost their minds and have basically stuffed themselves, gouged themselves. And that's been an unfortunate view of obesity for quite a while. And it wasn't until around the 60s that surgeons started to look at this whole issue of obesity in terms of there got to be something that surgery can do to assist, because the medical interventions up until that point in time were proven to be extremely dangerous, deleterious to patients. Some patients died from the medication. Some of the medications, in fact, were withdrawn. And since the 60s, the obesity as an epidemic, you can almost track it. And it's one of those curves that's kind of doing that rise of an airplane, meaning that the rate at which obesity is increasing worldwide, that also is increasing. So what I want to achieve tonight is for you to regard obesity perhaps in two parts. Yes, one part of it has to do with how much you eat, what you eat, choices, frequency, etc. of food and drink. Something to do with your total calorie energy input exceeding your output. And that's a generally simplistic view, but that's part one. It's a two-part story. The second part has to do with, and I hope you leave here tonight with an appreciation of the role of the fat cell. And the fat cell becomes your enemy the more fat you deposit, because it has significant substances that prevent you from losing weight. It's almost like a conspiracy, and those of you who have tried to lose weight know that there is something in your body conspiring against you despite your greatest effort. And when you see persons who are 700, 800, 1,000 pounds, unable to move, but they have persistent obesity, it begs then you to consider that there has to be something else going on. There has to be almost a cancer-like activity of the fat cell that is contributing. So obesity is about excess energy being deposited as fat. That's true, but another part of it is extremely important, that you appreciate the role of the fat cell. And that's what intrigues us then in the medical profession when we treat obesity in 2017. So with that in mind, I'm sure you would have multiple questions, but at least questions with a backdrop of, I'm now looking at obesity in a different way. So I have my superstars here with me tonight to assist the presentation, and all of them were a different person at some point in time. They all had another person attached to them, and they have wonderful stories about what it is that got them to this stage. But I just want to, at this point, let them introduce themselves so that you know who they are, a little snapshot of their journey, and they become the ones, interestingly enough, who are much more qualified than I am to probably answer most of your questions. So we'll start with Chanel.
Good evening. My name is Chanel. I had my surgery September 13, 2014. I started off at the whole program at 230 pounds. I got to a point where my cholesterol level was extremely high. My doctor was threatening, "Oh, Chanel, you need to go on Lipitor." He's telling me, "Oh, every month we need to check your liver function. giving me the rundown. I said, what? No, I'm not going on any medication. He said, but you need to lose weight. My knees are hurting, sir. I can't do it. And I said, Lord, I'm on glucophage. I'm going on Lipitor now. I need some help. And I spoke to one of my coworkers who had the surgery. And I think that's the best thing that has ever happened to me. I'm now 165, no more aches. I'm off the glucophage. My cholesterol level is low. And I feel fantastic. Fantastic.
Good evening, everyone. My name is Patrick Kemp. I had my surgery on the 24th of March, 2016. I weighed at that point 394 pounds. My surgery came as a result of me having severe sleep apnea. After a night of doing a study at Dr. Moss's office, my heart went into afibrillation. It was at that point that they realized if I did not get rid of the weight, then some other stuff would have happened. More than likely, I may have died. And so at this point, I would have lost 140 pounds and still counting. And so we want to see where it is that we're going to go.
Good evening. I'm Chantal. I had my surgery July 9th, 2016. And even though my sister had her surgery a few years before me, I still wasn't at the point to whereas I felt like I needed to do gastric sleeve surgery. It wasn't until, well, I was already a diabetic. It wasn't until my doctor had put me on Norvasc, hypertension medication, that I realized something had to change. My mom and my dad, they're both diabetic, type 2 diabetics, on hypertensive medication, both with cancer. So I was like 2 for 3, it was gonna be me. At the beginning of the program, I was 235 pounds. I'm now 170 pounds. No metformin, no Norvasc, and I feel excellent. I exercise when I could. I'm a full-time student, but what I do, I park on one end of the campus and walk to the other for class, and if I need to get home, I gotta find my way to the car, right? So I track everything on my Fitbit. So there's no excuse for not getting your exercises in. Okay.
Hi, I'm Jessica Robertson. I had the lap band in September of 2011. I lost about 100 pounds and did very well with that. Worked hard and it worked with me. Last September, I believe it was, I had to have the lap band removed, and in the same surgery, Dr. Diggis converted me to the gastric sleeve procedure. So I've had bariatric surgery twice now. It's like everyone else has said, it's life-changing. I was lucky, I was obese. I was 262 pounds, but I didn't have any comorbidities. I didn't have hypertension and all of that, but it was only a matter of time. Since I've had the surgeries, it's, you know, I tell everybody it's not a magic bullet, but for me, the surgery has made the exercising and the eating right work. I had, you know, from what Dr. Diggis said, I'm the biggest conspiracy theorist apparently. And so at this point, I've lost about 115 pounds. And I work hard to keep it off, but at least I know with the surgery that my efforts, unlike in the past, my efforts aren't going to be in vain.
Hello, I'm Sophia Moss. I started initially at 335 pounds. Just as Jessica, I had the lap band surgery in 2012. I had to be converted also to the gastro sleeve in 2015. As a result, I'm at 180 pounds at the moment, and I'm loving it. I've had to change a lot in my life, mainly because I don't like to say, but I think I was on the borderline, borderline of kidney and diabetes. And I was plagued with arthritis in my thorax spine. Of course, I was on pressure tablets, all of which made me extremely uncomfortable. So I've gotten rid of all of those, and I can say I am on no more medication other than if I feel like taking a tablet for a headache. I'm loving it.
Well, let's show them how great they are. Okay, let's do a tour and let's get a little educated. So we're going to talk about one procedure, the laparoscopic sleeve gastrectomy, of a whole number of procedures, but we'll keep it simple and we'll go a little bit at a clip. But obviously, if you have questions or queries, we're very happy to accommodate them at the end. In 1611, it was Cotgrave who actually described this phenomenon of obesity, coming from the Latin obesitas. You can appreciate historically that obesity was not a problem because we were hunter-gatherers historically, and we didn't have the luxuries as a species to be chilling and having things brought to us. There was no TV, no cable, no phones, no activity or lack of activity that would cause us to be sedentary. We were busy, we were moving. So it's no surprise then that obesity did not become a problem until the 17th century, 1600. And since then, it's kind of nibbled along, and like I said earlier, it's simply exploded since the 60s and 70s, and even more so now. The sleeve, so what do? We obviously put you asleep. It's a laparoscopic procedure, meaning it's a pinhole surgery. We only go through particular holes in your abdomen. We blow the space up so we can have room to operate with instruments that we introduce. And essentially what we're doing is removing about 60 or 70% of your stomach. And this top part of the stomach is an interesting part that I want you to be mindful of, because that's where the hormone ghrelin, think about growling, it's the hunger hormone. And so the more of that we remove, then the more we control hunger, which you appreciate is a strong drive towards eating frequently, wrong choices, and developing obesity. There are other features of the sleeve that we will speak to later on, but I think it's simply important for you to know that the sleeve has become the most popular operation now because it does achieve the endpoint intended, and it has fewer complications than the other more dramatic procedures. And two of the patients mentioned an issue with the lap band. The lap band was great. I loved the lap band, introduced it in the Bahamas in 2008. It was great. In fact, some patients continue to swear by it and indicate to me that they're not giving their band back to me, which is great because they're doing well with it. However, its complications, when it slips, can create significant problems requiring us to remove it. When we define obesity, other than talking about the absolute weight, we also talk about a body mass index. And the body mass index is a pretty accurate way, but it really would not apply if you were weightlifting, if you had a lot of muscle mass. So somebody with a whole lot of muscle may have a high BMI, but they don't have a lot of fat. And so we also speak beyond the BMI about the percentage of body fat. Like men would have about a 25% body fat, and women would have usually 35% body fat. And as the fat percentage increases, then you're depositing more fat, whether that's in the abdomen or under the skin on the rest of the body. And you can then understand that the more you deposit, then the more obesity becomes a manifest problem. And there are ways for us to measure that. So your waist-hip ratio is commonly spoken to. So for men, if you get to 40 inches, you're in trouble for a whole lot of reasons. You need to back off the 40-inch waist and bring it right back down to the lower 30s. For women, it's sometimes the dress size. As you start to get up to 16, 18, 20, and then it goes off the scale sometimes, then you know as you get 18, 20, and then you go to a different store, you're in trouble. And this is when you get significantly the cardiovascular risk factors. So bear in mind that as your deposition of fat in the central area increases, which is unfortunately what happens to most of us. We would like fat in some places, not the places that it tends to go, but the places that it does go can cause us to have increased risk factors. We're not going to spend a whole lot of time on the why and how you become obese, but only to make the point that obesity is regarded as a dysfunction of metabolism. And that's what this slide is all about. There are other things going on as well, but the disordered metabolism is what I want to leave with you. Now, recently there's been a lot of focus in the scientific community on the role of what we call the fecal microbiome. And there's an appreciation when you say microbiome that the bacteria that reside on and within us actually play a protective role. And so when you hear about fecal microbiome transplant being applied as a treatment, then what that means is that we're taking some of the good bacteria out of the feces of volunteers, and we're using that good bacteria transplanted into the colon to treat particular conditions. And the reason why that becomes significant is because the good bacteria reverses or arrests the inflammation, which is the thing that's mediating how you're becoming obese, how you're developing a particular illness. So in your chronic inflammatory diseases, rheumatoid arthritis, ulcerative colitis, Crohn's disease, there are a number of conditions where the feature is chronic inflammation. And having a normal flora is important to reverse that. And the problem quite often is if you take a whole lot of antibiotics, you're going to change what we call your flora. You're going to change the bacteria that normally occupy your colon. And the idea is to get back to healthy bacteria. So you will see something about that. There's also an association with particular infections in the past, but this is only in 5 to 7% of individuals where you can find the antibody to particular bugs that may cause a cold or a flu-like illness. But this is not the main reason why persons become obese. These are some of the edges. The body mass index developed by Accredited back in 1840, and it's become the standard that we use when we talk about obesity. Whatever your current weight is, you have in your head a goal BMI. You know exactly where you need to be, but you also know that there's an excess body weight. And that excess body weight is what you're going to pay a lot of attention to. And in surgery, what we pay attention to is the extent to which you lose the excess body weight. And we consider it successful if we can get you to lose 50% of your excess body weight. Now, obviously, with some of my stars over here, they've gotten that all the way down to 100% of excess body weight. But your target reasonably would be if I could get down to 50%, then I am at least doing well enough. Overweight and obesity a problem, and underweight also a problem. So you don't want your BMI to be under 18. You become particularly prone to infections, prone to a whole variety of illnesses. Your immune system is compromised. So as overweight and obesity is a problem, so is underweight. And your normal weight, you want to stay in that zone between 18 and 24. Of course, a number of us would not have seen a BMI of 24 for a while. Yours truly included. So just be mindful that as you set a goal for yourself, the reference BMI of 25 is ideal. And a lot of my patients know that my reference BMI is around 30. If I could get you to 30, we have achieved lots. We could work on the rest after that, because most of the patients you appreciate start off at 45, 50, 60. So if you can bring that journey down to 30 or a body weight of about 200 pounds, well, we got some good goals. But this is the science, 25, so bear that in mind. Overweight, if you get up to 30. And so a lot of the Bahamas, for example, the adult population, last numbers had adult population of 60 to 70% either overweight or obese, and the vast majority of them are sitting in this range. Of course, this is the problem, or where the problem begins. at a BMI of 30. And then once you get to 35, you're more severe. And then you get to 50, the morbid obesity. That's a scientific term. Quite a number of patients also are not happy with being referred to as morbid, but it's scientific, nothing to do with them, I point out. So it's not a personal attachment, but when they see the diagnosis as morbid obesity, morbid has a connection to death, and so they're not happy with that term. But anyway, it's scientific, and we don't put a death sentence on you. But then we also have quite a notable number of these individuals who are super obese, and sometimes we don't have the scale, because at 500 pounds, that scale may max out, and there are individuals, obviously, who are over 500 pounds. So what can go wrong? And we'll just do a tour of what can go wrong. There's so many things that can go wrong that, it's quieting sometimes when you look at the long list and you realize that, well, if so many things can go wrong, then why is it that we're not paying a whole lot of attention to it? Well, that's a good question for you to bear in mind as this epidemic of obesity continues. So the coronary artery disease, these are the diseases of the blood vessels around your heart. You can get heart attacks, early onset of heart attacks that can cause death. Hypertension is a disease that it's in one of those, the list of our chronic non-communicable diseases. High cholesterol, some of our superstars mentioned that, and type 2 diabetes. These are some of the problems commonly associated with obesity. And with type 2 diabetes, which is so notable because there's also an explosion of type 2 diabetes, there's explosion of obesity. If you look at the obesity graph and you look at the type 2 diabetes graph, it's almost the same. So be mindful that you're probably pre-diabetic if you sit in that class 1 obesity, even if it hasn't manifested. If you do a particular test to find out whether you indeed have diabetes, you're probably going to find out that you have pre-diabetes. And this is because even though you're challenging your system with what we call, for example, high glycemic foods. Let me talk about that a little. So if you look at the foods that you purchase on the labels, you'll see they start to talk about the glycemic index. All that means is that there's certain carbohydrates. When you eat them, they cause a surge, a rush in your blood sugar. And those kind of carbohydrates are commonly in anything you have to tear open. Now, I'm not against a Kit Kat, but I can pick on Kit Kat because that's the easy one. So you got to tear that open, you eat that. Those carbs, those sugars, when you absorb them, the glycemic index is high, towards 100. And that causes a rush from your pancreas of insulin. And that causes a drop in your blood sugar. And some of you would know that after a big meal, depending on the type of calories that you consume, your blood sugar just drops and you get sleepy. Well, the reason for that would be that there's this insulin load, this insulin rush. So high glycemic index foods, if you're going to take a note, these are the foods that you want to avoid because they're pushing your pancreas and they're causing a surge. Now, unfortunately, over time, your body develops a resistance to insulin. So even the insulin that is put out, intended to control that high level of blood sugar, there's a resistance to it. So it's almost like a conspiracy going on. You still have high blood sugar, even if your insulin is high. That's a theme that's carried through with obesity. So you need to bear in mind that there are additional things going on beyond what's obvious. And the thing that's happening with insulin is an example of the additional things that's going on. It's not simply, oh, you're taking the calories and you deposit them. The hormones that you have working for you, sometimes your body develops a resistance to them because insulin will obviously mobilize that energy and cause the storage of fat. But bear in mind that the insulin resistance then on this slide is what you're paying some attention to. You can have it working for you, but it also eventually works against you. The HbA1c and prediabetes is basically what we spoke about earlier, and I just wanted to make sure that we paid particular attention to the relationship between obesity and type 2 diabetes. And if in doubt, then you could do your HbA1c, and you'll see that if it's elevated, going towards the 7, 8, 9, that's the territory of diabetes, even if you haven't manifested symptoms. headaches, stroke, heart disease or heart failure, problems with the lung, problems breathing. Patrick mentioned the obstructive sleep apnea, which is a big problem because obstructive sleep apnea also causes problems with your heart. Because when you stop breathing and your carbon dioxide builds up and the strain occurs on your heart, you can imagine doing that night in, night out, and then for years, and then you run into heart disease. And that's why that becomes significant. The hypoventilation syndrome is a syndrome where sometimes you see people who happen to be either weight challenged, if you want to describe it that way, or obese. During the course of the day, they fall asleep. They fall asleep like in the middle of a sentence because their ventilation is low, the carbon dioxide builds up, and they become, if you like, narcotic. And they just fall asleep. Easy to wake up, but easy to fall asleep. So that's the part of that hypoventilation syndrome that is also related to obstructive sleep apnea, both dangerous conditions. Fatty liver disease is very important. The most common reason for transplant of the liver today is non-alcoholic fatty liver disease from obesity. Inflammation of the pancreas. Metabolic syndrome is just a syndrome that includes a whole list, 3 or 4 of the items that we already discussed. And the cancer. Chantal mentioned cancer in her parents, but cancer associated with obesity happened to be increased. And these are some of the list. And more. Additional things that are going on. Well, superstars mentioned the problems with the knees, problems with the back, arthritis in the knees and the backs, going to needing joint replacement. In fact, there are quite a number of patients who end up getting joints replaced, and you look at them, and some of them are 300 pounds, and you ask whether that's the cart before the horse. Back pain, gout, a lot of leg skin disorders. You know, the leg swells, there's changes of the skin, hyperpigmentation, ulcer, the whole gamut of stuff can happen with chronic, long-term obesity. Infertility in women, and then polycystic ovarian syndrome is a very common disorder with women who are obese. GERD or reflux, heartburn, indigestion. And then this list. This is probably the overlooked list, and this explains why these patients tend not to go out. They got emotional issue, major depressive disorders, low self-worth, and low self-esteem. Well, obviously, this panel don't have that issue, but you could appreciate that if you go to the other end of the spectrum some time ago, then that may have applied. But let's just say that that's not an issue that they have currently. Hygiene issues, the ability to reach and clean themselves, and then social issues, just being totally discriminated against. You go on an aircraft and you got to make a decision. How many seats you're going to occupy? So let's talk about food and the relationship with food. And I think it's important for us to appreciate, and I'll kind of let the panel chime in, this whole issue about food choices, preparation, the frequency, the amount, night eating, binge eating, emotional eating. Maybe talk about the relationship with food. Get a volunteer to speak about that relationship with food. One of the issues as they decide amongst themselves who's going to volunteer, who got the microphone? That's my volunteer. All right, so one of the issues to come to terms with is, what is my relationship with food? So Jessica, how do you deal with that? How do you deal with your relationship with food? I know you got to go way back a little and remember this, but how do you deal with this relationship?
When I was in the closet this morning, I looked in the back looking for what to wear tonight, as Dr. Diggis said.
You should have worn that.
Okay. Well, it was funny because I went in, and I think a lot of, we talk about where we started and where we are now, and it's very hard for me. I've been about this size. I've had plateaus. Dr. Diggis can talk about my plateaus. But I've been about this size, and most of you would know me as this. And it's taken me a while to get used to this. I kind of catch myself originally in the mirror and go, oh, that's me. Because you're used to seeing yourself in a different way. I mean, the mind's a fascinating thing. But when I was getting dressed this morning, I went in the closet and I looked in the back, and I have a couple of things that I kept from before I had surgery at all. And I think that, you know, we can talk about numbers, but I think these were the pants and these were tight. I think I might be able to fit in one. Yeah. But I think that's a very good visual, because this is real. These were my pants.
That's the other person.
Yeah. Me and someone else used to wear these. But it's real, and I have to look at it every once in a while, because you kind of get used to it and you get a little complacent, and you know, this is a lifetime journey, and sometimes you kind of get complacent and you have to remember where you came from to remember where you got to keep going to, because it does take a lot of work. I don't think anyone here will lie when you hear people say, "Oh, that surgery is the easy way out." I mean, nothing's easy about surgery.
Superstar.
6 years.
Yeah, and the role of that, maybe Sophie could elaborate a little. The role of that, using the gastric sleeve as a tool, the role of that discipline, the role of that stop, because I know that in your journey you've had your moments. Maybe you could speak to the role of the surgery, the restriction, in assisting you with dealing with your relationship with food.
Right. I, unlike Jessica, I love food. Right now, I love the Food Channel. I continuously watch it because I cannot get enough of it. But in my past life, I can go to a party and know for a fact that I'm going to eat, and then I'm going to take up some to carry, and I'm going to eat again. And that change was real to me when I realized that what you cannot get down, what is it? How do you say it? You can only eat what you can get in, and there's not much room. So my life has changed a whole lot. I've had to make decisions about, hey, I just love potato salad, but I know if I taste a little teaspoon of potato salad, the space is gone. And I'm having to say to myself, you want a potato salad or you want a piece of macaroni? And either way, the space is gone. So I'd make wise decisions like having me some salad and then maybe taste a piece of meat. And I'm satisfied.
So food addiction was real with you?
It was real, yeah. But right now, you cannot put in what you can't get down.
One of the points, too, is this whole role of processed foods. And I don't want to diminish the significance of that, because when you talk about the explosion in the obesity epidemic, you want to appreciate that a part of that has to do with the foods and the drinks and the way that has been changed and what has been added to that over time. So that's playing a role as well. So you want to, make a note and pay particular attention to what it is you're choosing to eat, especially if you have to tear it open. Just have a moment to think about that. There's certain things that would be put into that, supplements or additives that could preserve its life long enough for you to have a year before you get to eat it. Well, you want to think about what it is that's causing that food to be still good for you a year later, and what that may be doing to contribute to your own obesity. Understand, too, that there is this issue when it comes to appreciating the role of sugar and salt. There's a definite industry of salt and sugar and getting you addicted to salt and sugar. So there are people who go to work, if you like, and their whole purpose is to figure out ways of getting your taste buds attracted to salt and sugar. And you can think about there's certain foods, Doritos, etc., you can't eat one. And if that, in fact, has been modified so well, then you start to understand, wow, that's why. Because if I can get your taste so hooked to it, then I can get you so addicted to it, you have no choice. So that's an industry. Food triggers, and it's important to understand as well that binge eating, night eating, emotional eating, these are all contributors. And sometimes, you can get up at night, either prepare food or get a big pack of something, and in that big pack of something, you're putting away about 1,000 calories. Of course, when I ask you, what do you eat? You're not eating anything in a day, which may be true, But at night now, since I didn't ask that question, that's a different story. Sleep plays a role as well. So too little, disordered sleep, and quite a number of conditions that obese patients have, like obstructive sleep apnea, which causes them to have to wake up. You know, you think that, oh, I got to wake up and go to the bathroom, but waking up and going to the bathroom 2, 3, 4 times a night is really triggered by the sleep apnea, not by the desire to go to the bathroom. You just happen to be up, so you go. Of course, going to the bathroom may also mean that you have, if you go in 2, 3 times a night, you also have some undiagnosed diabetes going on, because that also causes you to want to go to the bathroom. So you have these two things happening when it comes to the issue of getting up at night and not being able to sleep for more than 2 or 3 hours. So make a note of that. So we mentioned this thing about the fat cell, and I do want you to appreciate the fat cell is, yes, it's your enemy because you put a lot of it in your body, and especially adolescent obesity. During adolescence, if you have what they call hypercellular obesity, and all that means is more and more fat cells are deposited. And we also appreciate that amongst adolescents, obesity is on the rise. And so the more adolescents become obese, the more they are manifesting the hypercellular obesity. When they become adults, it switches into the hypertrophic obesity, meaning the cells become full and more full of fat. And the most difficult thing to do, unless we excise it surgically, is to get rid of the cells. You can get rid of the fat in the cells, but the cells don't simply pop up and go when you lose weight. So these substances within the cells, these are pro-inflammatory substances. And these pro-inflammatory substances then are playing a role in obesity. So that's the very important thing that I want you to be mindful of. That obesity, beyond this whole issue of the energy-calorie balance, too much in and not enough being burnt off, is also a story about the inflammatory consequences, the pro-inflammatory consequences of the fat cells. The other thing that fat does is, as the more you put on, the more it reduces your metabolic rate. That's an enemy. You'd like to think that the more fat you put on, the more you're able to burn, more if your metabolic rate went up, that would assist you. But the more you put on, the more your metabolic rate goes down. And in fact, it also works that way when you try to lose weight. So 10 to 15% of weight loss, the metabolic rate drops, so it's even more difficult to lose more weight. Whose idea was that in the design? Genetics are associated with obesity, and one parent being obese, high risk. Both parents obese, definite risk. This thrifty gene hypothesis is really referring to a time when we were hunter-gatherers. And so what we had to do was to get all of our calories when we caught an animal and killed an animal, and we had to store, because you don't know where you're going to be next and when you're going to get food again. So the storage issue, the ability to store energy as fat, was important, and that's what that hypothesis is about. Now things have changed. You know, you don't have to necessarily run the chicken down. It's prepared for you. You can go and purchase it. A whole variety of ways. So hunter-gathering has moved away, but of course, the storage issue, as we could see, has not. And then there are medications, and it's important to appreciate that there are certain groups of medications that do cause you to put on weight. Antidepressants, some of the diabetic treatments, and then some of the hormonal treatments. And being on steroids, for example, for a whole variety of conditions, that's a very common reason why you continue either to fail to lose weight or indeed put weight on. Physical activity, there's no question that it plays a role, but if you think about it, if you're not able to, because at 1,000 pounds or so, if you're not able to get out of bed, then the conversation about physical activity is really useless to you, at least physical activity in its traditional sense. Now, we can get you in a pool where your weight is displaced, and you can now exercise not having to do the impact type of exercising, then fine. So there are ways to get you to burn calories in a physical activity sense other than having to walk or go to a gym. but I don't want you to undervalue the importance of and the big contribution that simply walking would make. If you can burn your 300 to 500 calories a day, you're right on top of the game, consistently. But if you sit down for 3 hours at a TV, then over time it's shown with adults, you've increased your risk for heart disease, cardiovascular disease, and diabetes mellitus. That's a sobering thought. I know nobody in here sits down at the TV for more than 3 hours a day, so. There's some endocrine conditions that you need to be mindful of, and that's why we talk about, boy, she must have a hormone problem. Well, to an extent, it's an important question. And that hormone problem then needs to be discerned. Is it something to do with a low thyroid, something wrong with the estrogens? Is there something about the cortisol, or diseases like of the main, the master gland, or diseases of the adrenal gland? There are hormonal issues that need to be addressed, and we address that in the workup. We mentioned earlier that the significance of obesity is so much so that in most of the industrialized nations, 60-ish% of the adult population happen to be overweight or obese, and that's increasing. And that's a very sobering reality, because as time passes, more and more persons are contributing to this burden, if you like, this disease burden of obesity. And it's something that gets more and more on our radar because so many more people are presenting either with obesity without diseases, but obesity with a whole list of other issues, a whole list of morbidities. And the lost productivity is also a very significant factor. Time off from work, not able to work at the particular level of efficiency or productivity. You can imagine the cost that also does add to the whole issue of obesity. So obesity brings a whole number of areas of cost. Lost income, lost productivity is a significant one. And when we look at the cost, we got to look at the treatment of the obesity, the treatment of all the diseases associated with it, but also how much does it cost us as a society for the lost productivity, time off from work because of so many things going on that you can't come to work. And if you're at work, so many things, again, going on with you that you're not able to function productively. So let's look at the sleeve a little bit then. And let me go back to the panel and ask them, what really got you to make a decision that, okay, this is it? And I know, Chanel, you mentioned that earlier. What caused you to say, okay, now this is it, I am going to have surgery because? What was that because that convinced you, we got to put you to sleep, there's a risk of putting you to sleep, you got to have somebody perform an operation on you that has particular complications, but you say, despite that, this is it. What was the this is it moment for you?
I basically said, either I make up my mind to go through the surgery and live longer, but the rate that I was going at, I know I was going to an early grave. I knew that. And me having 2 young kids, I wanted to live a healthier life for them.
Right. So it was really being able to live. It was a life or death choice for you. If you continued on this path, then you could see disease and early death.
Yes,
Yeah.
yes.
All right. And Patrick, you mentioned earlier as well in the decision for surgery, I know you had a lot of challenges that caused us, in fact, to spend some time before surgery. So what triggered it for you?
For me, it was actually sitting on that bed and hearing the monitors go off and realizing that we were almost at the end of it right then.
Yeah.
My family who lived on the island were on the way down because they did not know if they would get here before I would get into the ICU.
Right.
Because they already had me tagged to go up to ICU. I was already on the medication for my heart. And we realized right then I'm sitting on that bed and my wife is there. We've not been married for 6 years yet. And I just realized that I was being extremely selfish. I was eating myself into a grave, and there was my family. They were just prepared I don't think they were prepared to just cry for me. How do you just lose someone for them just being selfish? You're just eating, you're just enjoying it. Like the lady said, me and food, we had an affair going on over this world. We were madly in love, man. We were deeply in love. I mean, we were deeply in love, and as a result of it, that's where I found myself at a point where it was either do it or just die. And here I am. Here I was at 34, 35, and having to see a heart doctor, having to see the sleep apnea doctor, having to see Dr. Diggis. It was just one doctor after the next. And even though the insurance was taking care of it and taking care of most of it, psychologically, that was the hard part. Every day it was something different, something else going on. When night came and it was time to go to bed, I slept with a mask for about 6 years. I had to use a mask to sleep. And even then, you wake up in the morning and you get up at 7, and by 9 it's time to go back to bed because you're exhausted. Can't make it. They did surgery to remove the tonsils and all that stuff out of the throat, but there was so much stuff inside of there, I guess, so much fat that couldn't happen. And eventually it took a toll on my heart, and my heart started to freak out. And so I had to decide that either I'm going to do this for my family or I'm going to allow them to do something for me.
Yeah.
And that was going to be to bury me.
We spent about 4 months actually trying to get Patrick in an ideal state to tolerate the surgery. So it's not a surgery that you would want to take lightly. We got to put you to sleep, but in putting you to sleep, we also got to wake you up, and it'll be a good idea for you to wake up and return to your family. And so you could appreciate then the significance of having the surgery really divides into two parts. One is the anesthesia issues and being able to be safely anesthetized, but the other is to recover as well from the surgery. And as you see, those were some challenging decisions because we spent quite a while before surgery, and he had lots of opportunities to change his mind. So when you look at the panel of what's available, back in 2013, you'll see that the sleeve gastrectomy had actually become a pretty significant number one. And historically, the bypass, the gastric bypass, which is a lot of restriction, but as well as malabsorption. And the malabsorption part of it, and by that I mean we short circuit the bowel. We divert food from one point and push it down lower. That produces a lot of issues, a lot of complications, and the complications have gotten to the point where the patients over time regarded as intolerable. Hence, a simpler procedure that does not have the malabsorption component, that does not have those complications, has arisen then and become the one that's most popular. So back in 2013, this is what it looked like. And more recently, 2015, the sleeve gastrectomy had moved to 50%. And in 2017, you can imagine that it's even moving further north as the operation of choice. And it's the reason why that is happening is that you can move from a sleeve to a bypass, but it's not able to be done the other way around. So a sleeve becomes like an introductory procedure for you. If you think about, well, I may be able to benefit much more from a bypass because I have 700, 800 pounds of body weight. Well, that may indeed be so, but if you're going to use multiple modalities, multiple efforts in trying to get your weight down, and you don't want to initially deal with the attendant complications or morbidities associated with a more complex, a more involved, a malabsorptive operation, then you can understand why the sleeve has become what it's become. So the bypass is reduced. The band, again, the experience that patients have with the band, the fact that it can suddenly obstruct your stomach, and we don't have a long time. When you get absolute obstruction, then we actually have to get in there, remove the band, relieve the obstruction from the stomach before that pouch in the stomach actually ruptures. So the band does pose a significant problem if it slips. And then revisions So a very important point to make is the surgery that both Sophie and Jessica would have had would have been a revisional procedure because the band slipped. So we moved from one procedure to the next in one sitting. So we used the sleeve gastrectomy to treat type 2 diabetes, as I mentioned, significantly. So if you have type 2 diabetes as well as obesity, or you're pre-diabetic, then you see that you're using the one operation to treat two epidemics. And these are the results from the trials that looked at, so how effective is the sleeve gastrectomy for diabetes? And without a doubt, it is. This is from the American Society of Metabolic and Bariatric Surgeons back in 2012 that basically established then the sleeve gastrectomy as a standard, improving the quality of life and giving you durable weight loss, which is what we look for. And one of the things that the members of the panel have shown you is when it comes to treating obesity, it's not whether what you try will work. It's whether what you try will cause you to get to sustained weight loss. And so we talk not so much about obesity being treated with surgery. We talk more about obesity being treated with surgery as one of the tools, because going forward you would still have to continue to do quite a number of things. And a lot of the panel members have touched on the fact that it wasn't surgery alone. Because if you use surgery alone, you will find that if you slip back, you can put a lot of pressure on that residual pouch. You can still go back to poor choices. You can lead a sedentary lifestyle. You can have the same stresses come back and cause you to move towards gradually putting that weight back on. So you are mindful then that the surgery is one tool. It's an important tool, but it also needs you to add additional things so that you end up with a sustained weight loss. And this is what we try to remind the patients, that don't just focus on the surgery. Bear in mind that obesity is a journey for life. And if you understand it that way, then you will continue to implement the interventions that we speak about prior to surgery so that you will have success in the journey. So I just want to take a moment to allow the panel to talk about particular things that they do now, just to create an echo of that message. What is it that they do now after surgery, after the sleeve gastrectomy, to make sure that they at least sustain that weight loss?
Well, with me, with my relationship with food, I was an emotional eater. I discovered that during the program, actually, when with the counseling meetings and what have you, when I was stressed, I didn't even realize I was going to the fridge and eating and what have you. But one of the ways I've learned now not to use food as a comfort, I either meditate, I jog in place and all. If I'm at home studying, I'm with the book, jogging in place, because moving, that helps with stress too, I've learned. But yeah, I don't use food as a coping mechanism anymore. And with the exercising, if I can't go on the highway, because I usually walk, if I can't get on that highway, like I said, if I have class on one end of the campus, I park on the other end and I walk to the class, come back, and I track my steps with Fitbits and what have you like that. But walking is the way I get sustained, and I watch what I eat too. You could, like Dr. Diggis said, you could fall right back into that trap of eating the horrible stuff. We come from a culture. Our Bahamian culture, our culture is the food, the macaroni, the rice, the pea. It's silly to think that you're not going to eat those things anymore. But then you try to keep in mind that it's portion sizes. You don't have to have the whole pan of, well, you can't get it down anyhow. But if you go, you go pick up the plate with the rice, the macaroni, the potato salad, you go waste your food. If you pick up that rice and you sit there and you eating that rice, you're not going to finish the rest. So you make mindful choices when you put that on your plate to know that you put your salad, your protein, well, we're supposed to eat our protein first. We eat our protein first, the meat or what have you, and we do vegetables next and what have you. But you learn along the way you find whereas you eat the proper way to sustain. And you going through all of this, you don't want to go through this for no reason, you know? You're gonna take care of your body after a while. You're not gonna just eat these horrible things anymore. You're not gonna even want those anymore. I don't know about anybody else, but before surgery, cheesecake was my thing. I haven't even had a slice of cheesecake since surgery. You lose the taste for certain things. I don't know if anybody else, right? So you're gonna sustain it, but it's a tool. It's a tool. It's not a magic bullet like everybody think, oh, you went the easy way out. I've heard persons tell me that before. And after I explained to them, no, it's not the easy way out. It's just a tool that assists me in getting to a healthy weight where I can live longer for my child. That's it.
Yeah. So you have the control of your appetite, which is great. There are also certain food choices that you no longer tolerate, which is really great. So why weight loss surgery? Well, because it works. Because this is where you use this tool and you add on the discipline that the panel has spoken about to get to sustained weight loss. You get improvement in your comorbidities. Nothing better than getting rid of all those medications. 90% of the medical problems either improve or resolve. I mean, that's wonderful. Hypertension, diabetes, etc. The stories are there. The long-term mortality, being able to live and being able to have quality life, both are important. So, if somebody asked you about weight loss surgery, how do you qualify for it? And these are the criteria. And generally, if you find you're at 250 or more, 300, yes. You're not a weightlifter, you're not muscly. So 300, 350, 400, yes. And so most of where we have our patients is somewhere between that 250 and 400 pounds. But these are some of the things that you want to make sure you've paid attention to. Weight loss efforts in the past, you've failed them, and a lot of insurance companies would require that in any event. You have a sound mental state, and we do send you to a counselor to make sure that, you know, you're not going to come back to me and ask me for your stomach back. So it's important for your insight, for your motivation, for how you understand the journey to be established. The endocrine causes that we talked about, exclude those. And then there's a certain body mass index, but we have no issues, no problems qualifying for the body mass index in the Bahamas. Most of our patients would come in at around 300 pounds in any event as a start. There's certain things that increase the operative risk. Just want to point this out. These are more our issues, and you know, looking at Patrick's story, then we have to make sure that if you have high operative risk, that we pay attention to that and we control for that. So we mitigate a lot of these issues in the pre-operative preparation. So what are the advantages, the specific advantages of the gastric sleeve? And we mentioned some of them. So this slide basically is to remind you of specifically why would you choose or recommend or even have a conversation with somebody about the sleeve gastrectomy. So you get early fullness, and that is a gift to persons and patients who are addicted to food. If you're full early, bang, that stops you. There's only so much you can eat. We've removed your appetite driver, the animal within that's growling, that wants you to eat more. It's restrictive, so your meals are small, more frequent, but small. Again, you have to balance that with your choices. If you took a cheesecake, you could get it through the pouch. So it's only restrictive given your protein going in first. It doesn't change your your GI tract, doesn't change your anatomy like the other malabsorptive procedures. And if for whatever reason you failed with the sleeve and you put on a lot of weight, it can be converted to a bypass. But it is a high pressure gastric tube. It's like a banana, and you're moving from a flattened volleyball to a banana. And in doing that, you can imagine the pressure in that system is a little higher, so there's a tendency for stuff to reflux. So patients who already have reflux, we warn them, but sometimes we just tighten up that controlling muscle between the esophagus, the gullet, and the stomach, so that that's not really a problem after the surgery. So those are the advantages or benefits. And then some of the results when you compare, you see with the bypass, the excess body weight, 65 to 70%. Long term, you can have about a 20% weight regain. And when you talk about long term, you're talking about 10 years. So really to measure the success of any particular modality, you want to look at its long term. Is it durable? And so you can get about 1,000 different things, ways, diets, so many different recommendations about weight loss. Yes, do they work? And my response to most of my patients would be, if they're really concerned about whether they choose Atkins or Mediterranean, or you got a whole list of diets, you got a whole list of other things that come along, almost like the flavor of the month when it comes to, here's a new treatment for obesity. And if it's safe, then fine. I don't have an issue with it. If it's not going to cause harm to you, it's not going to compromise the ability to treat your comorbidities, that's fine. But if you look at 10 years down the road, is this something that you're going to do for 10 years? And if you look at the results 10 years down the road, do the results show that whatever you've chosen has resulted in sustained weight loss? And you have to evaluate it like that. Don't be so attracted to, man, you know, I got this wedding to go to in 3 months, I need to move from a 20 to 8 to 18. You know, that's not the way to do that. So, you know, you got some other modalities like, you know, well, why not do a gastric balloon? Why not just put a balloon in my stomach and occupy that space, take my appetite away, and leave it in there for 3 or 6 months? Well, true, you may lose about 30 pounds, but it has to come out in about 6 months, and now you're back to square one, but you've been, you know, you've gone through a whole procedure. So you got to think through long term, and don't be tempted to jumping into a particular flavor of the month because, well, you know, so-and-so said it worked for her, or so-and-so said it worked for him. It will work to an extent, but it may not give you the sustained results that you want. When you look at the band, 45 to 50% of the excess body weight, but long term, about 40% of the patients with a band regain the weight. And when you look at the sleeve, you could see that 60 to 70% of the excess body weight is lost, but in the long term, it looks like it's coming in around 20, 30%. But if you stay with a program, you can see that that number may come down. So you have to stay connected to whatever the program is, whatever the support is available for you. And we've done about 70 patients, band to sleeve about 10. And we haven't, fortunately, we haven't had any deaths. That's always important in a program like this. People don't like to think that they're going to come and die. Now, we don't control it totally, but we obviously would make a lot of effort to identify whatever problems you may have that needs controlling, and we control those. So we'd be particularly careful in the preoperative phase, try to get you through surgery as, you know, expeditiously and safely as possible, and then pay attention in that post-operative journey to all the things that you should be doing, moving around, using a breathing device, and, you know, mitigating all the possible complications that can lead to things like pneumonia or clots or sudden death. Like I say, so far, so good. So one of the things we spoke about earlier was just this whole issue, and to wrap it up, is to get you to understand that the body does this thing when it comes to your weight loss. And the message in this particular thing, this adaptive thermogenesis, is if you lose 10 or 15% of your body weight by whatever means, your energy expenditure reduces, your resting metabolism reduces. And that is a very important point, because then the effort it takes for you to lose weight further diminishes, is increased. Your ability to lose weight diminishes. So the same effort does not and will not result in your ability to lose weight. Very frustrating, but a very important point for you to retain. And quite often, the patients talk about this plateau. And understanding the plateau is what this is about. You get to particular levels. I mean, you're burning a whole lot of what you regard to be calories and energy. You're putting a lot of work in, but the scale, now that's a whole different subject. And, you know, I'm sure there are many scales that have gone missing in this, with this crew. But let's assume that the scale is correct and it's giving you information that says it's not moving or it's moving in the wrong direction for all the effort that you're putting in. And that's important to understand. And that plateauing adaptive thermogenesis essentially is saying at particular levels you're going to hold for a while as your body makes its own adaptation, and then it'll give again. You just have to persist with what it is you're doing. Most of the support group meetings, we spend time on this whole issue of, well, you know, I'm working, I'm doing, and ain't nothing happening. It's not moving. And that is true, and it has a reason behind it. Then the more weight you lose, the more metabolic slowing occurs. It's a conspiracy within. So you have to be mindful then that if you could kick in that 300 to 400 more calorie burn per day, then that would cause you to sustain your weight. So when you're in a plateau, you have to almost boost it by another 40 minutes of fairly active exercising just to avoid going back to that weight gain. But it's important that once you understand that, now you have a reason. It's nothing to do with you, it's all to do with how your body is making its adjustments as you come down. And that can go on from 6 months to 7 years, reassuring. So the final thing I want to talk about is how effective is diet. And you have a whole series of choices of diet, but one of the things that has been shown and supported by evidence is this whole thing about meal replacements. The ideal meal, if you think about it, is not so much you trying to figure out, do I have the right proteins? Do I have the right calorie or energy content in my proteins? Am I choosing the right calories, the right quality of calories? Do I have the right portion? Well, if you have that meal, now unfortunately with meal replacements, this is an industry that's developed. It does give you specifically what you require. It has been shown that if you comply and you stick with a meal replacement program, it turns out to be extremely effective. More effective than if you tried to do it yourself. But obviously it comes with a cost. So if you're able to create your own proteins, in which some of these experts have done, they have their own formula of what they can use. The pricing of the meal replacements sometimes may be at the same cost or even less than some of the expensive blends that you have to purchase. But if you can get the right protein, the right quality of carbs in the right proportion and not have to worry about making or fixing it, then you can understand why this is shown to be pretty successful. So evidence supports it, but it does come with a cost. So I want to basically wrap up on that point with a reminder then. We've gotten to the stage where meal replacements have joined the evidence in treating obesity. But when you look at the big picture, once you've made a decision for surgery, you qualify, you've done all the preparation, you've had surgery, you need to be mindful that this is still a journey that requires multiple modalities. There are lots of stresses and emotional challenges that will continue to come. You're going to have challenges along the journey where you're going to plateau, but you need to understand that plateauing is a part of the journey. You know that this is not only a matter of calories in, energy being deposited, and failure to burn. There's also what's going on in your fat cell, and the fat cell is contributing almost like an endocrine organ to perpetuating your obesity. And so understanding that, you then need to pay attention to your own body, because what works very well for one may not necessarily work well for you. There's a unique combination when it comes to sustaining weight loss after surgery. Each one of those combinations require a bit of a discipline. Now that's either unfortunate or not, but that really is what it is all about.
We hope you've learned a lot from this edition of the Doctors Hospital Distinguished Lecture Series. Please join us in the Loudon Conference Center on Dowsville Street every third Thursday for the monthly health talks, where you can feel free to ask your questions. Isn't your health worth it?